right here. And more so after COVID, too, or like during. So we shut down pediatrics. We were closed. PICU was closed. They stole it to the adults. We moved out. We had to sit outside the inpatient rooms on the regular peds floor that was pretty much empty. Also, if we had any critical kids, we'd sit outside their room, and thankfully there was a window there. We could kind of see in there. This was at Baptist. Children's, I don't know what happened over at Children's. Nobody was there. They all left. They were swabbing in the drive-thru. Swabs, that's where I was too. When I wasn't at the hospital, I was swabbing the drive-thru. Drive-thru, right? Thank you, drive-thru. So we weren't busy at all. And then the summer of 21, when everybody took their mask off, that's when they all started coming in. So all these babies came in with RSV, also rhinoenterovirus, parainfluenza, name it, they had it. Everything except COVID. They had all the things, all at once. Most of them were intubated, and they were struggling pretty bad. And it was because infants, newborns are exposed to viruses throughout their day, normally, and that trains, even though they might not have been exposed to RSV, but their bodies are trained to fight viruses, and they learn from other viruses how to fight new ones. And so when they didn't have any exposure, they pretty much had an immune system that had no experience. And then all the masks came off, we went out in the public, and we didn't think about these things. We weren't washing our hands like we should have been. Everybody was over it by then, right? And so all these babies were suffering from it. So, summer of 21, and it was bad before. Every winter, late winter, early spring, we have an RSV season. It's always been bad, but it was really bad that summer, and it just wouldn't go away. And it's now a 365 thing. I'm not sure about the last year because I've been with you guys, but I might have calmed down a little bit since then. But if you're going to go into pediatrics, you will see this. Okay. So it is an RNA pneumovirus, so a virus that can cause pneumonia. It starts out as cold-like symptoms, and not every baby's going to get hospital sick from it. Some are pretty lucky they get it. It's a little sniffles and a runny nose, and they're good. They're lucky. So we're going to talk about risk factors and some things that make it worse for certain kids. But even healthy children can end up in the hospital, and maybe even intubated with it. Usually it starts out because an older child or an adult comes home, they think they just have a runny nose. And for us, that's all it is. We won't even ever know we have it. And then our kid gets sick. So we ask about contacts, sick contacts, siblings, daycare. You guys probably are familiar with some of this. I don't know how much you really got into peds up until now. But that's a common question. If we have a sick kid coming into the clinic or the hospital, are they in daycare? Have they been around anybody sick? Because then we'll look at what season it is and what's the pathogen that's out there that providers are looking for, and then it kind of gives us an idea what might be going on. But as you know, with viruses, we don't treat the virus. It just kind of gives us a little idea of maybe what the pathology is going to look like for this kid. If they have the flu or RSV or all of the above. So, but for us, it might be a whole symptom. And now we're seeing it a lot more in geriatrics too, which it's always been there, just we thought it was a cold rhinovirus. They've never really tested for it, but we're seeing it show up more in our elderly now too. So, direct contact, it's a contact droplet, it's not airborne, larger droplets for this one. And we'll explain that in a little bit too. So, what does this virus do? It lines the respiratory tract, and it pretty much eats away at their epithelial cells on that surface of the bronchioles. And so it becomes this multinucleus cell when it attacks, and it basically makes a connection, which is the syncytia piece of it. So that one cell becomes one big large one with a couple of nuclei. So it makes this thick, nasty, gross skin cells within the lining of their respiratory tract. Causes inflammation, irritation. So you've got the swelling of the bronchioles, plus you've got buildup of mucus. That mucus is full of these cells too, like skin cells from the inside of your respiratory system. Looks like pizza cheese. Sorry, it always comes back to food, right? It is. It's like stringy pizza cheese. You'll pull an RSV booger out their nose and they'll snap right back. Yeah, they're coughing. If you see a kid with RSV, and I got some videos, that persistent, I mean, seriously, over and over again, exhausting watching these poor kids. It's coming up and snapping back. If you're looking inside their respiratory system, this thick stuff is just stringing back. It's so thick they can't cough it up. So think about what you're seeing and what's happening with that. This is why we call this an obstructive respiratory disorder. Okay, you've heard of obstructive respiratory disorders before, right? Chronic type. So, similar things happen to our kids here with the air trapping from this thick mucus, right? And all of those things depend, like, all of that depends on our treatment and how we're going to respond to it from the provider side and what we're watching for. That's, that they're prescribing for these kids. We're going to talk about treatment and how we handle this because there's been some changes over the years with RSV and how we're treating it. So who does it most likely affect? Well, think about it. We're talking about immune system, we're talking about viruses, respiratory. You guys just came from OB, kind of, right? So how does the fetus develop in utero? What is the last system to develop?
The lungs.
There you go. So who would be the first to be vulnerable? Premature, right? So we are scared for premature babies when they're born during RSV season. It's one of the concerns we have, and there are things we can do for them, but we know they are super high at risk. So infants and children with chronic lung disease, right? So they've already got lung damage. They can't handle all that of thick mucus going on in there with this super bad viral cold. Childcare settings, because of the spread of the infection, it's pretty easily spread. It lasts on surfaces for a couple of hours. So if a little kid's coming by and snotting, coughing all over the table, the next kid comes over and grabs something off of that table, fingers in their mouth. They like to share germs. They won't share toys, but they'll share their germs, right? The immune compromise. So these are things that you could probably logically think through who's at risk. Younger children. You all know about the anatomy inside an infant's lungs and a child's lungs in comparison to an adult, right? Maybe? Probably not something they touched on so much in anatomy. So we have significantly more alveoli as adults than children, and even younger infants, and even more so in the premature or newborn. They grow more. So if you're picturing the inside of your lungs like grapes on a stem, that's how I like to think of it. When you inhale, it's a grape, you exhale, or raisins in their little alveoli. That's how I picture it. We got a big cluster of grapes in our big adult lungs, but they don't have so much. So there's less surface area for that gas exchange to occur. So think about if there's sticky mucus in there, you're losing some of that alveoli, they get atelectasis. They can go hypoxic pretty quickly without all that surface area inside their lungs. So the younger they are, the more at risk they are. And then we can talk about the elderly and the flip side of that and the lung damage they have and all the lung diseases that might exist there, and they are more at risk for RSV. Of course, you throw the heart in there because if you're talking about gas exchange and oxygen and pumping, then anybody with heart problems is going to have backup maybe issues with their lungs and then fluid excess, and now you throw this virus in and it's all kinds of this. Okay. So those are all our risk factors. Some complications are essentially like what is happening here. So, all right, I've got pneumonia and bronchiolitis on the screen. Bronchiolitis is like a big respiratory umbrella in pediatrics. We can have bronchiolitis from several viruses. It's typically caused from RSV. And then the complication, of course, is if you get enough of that mucus that's sitting around, we worry about it growing bacteria, and then we have a bacterial type pneumonia, or just a generalized pneumonia because of that excess fluid in the lungs. I think I've got an x-ray in here somewhere. If not, it's in the video, you'll see a good little x-ray with clouding in that, their bronchioles. So initially, in the beginning, again, when I talk about cold-like symptoms, it might look like that for one of these kids. They could have like a runny nose for a couple of days, or even up to a week with a mild cough, and then start getting sick. It used to be, when I taught this about a decade ago, it used to be they'd peak at about the 5th day. So even if I was talking to a parent and I asked them, well, when did you notice symptoms? Usually it starts with the runny nose. And they'd say like 3 days ago. I know in my head, ooh, we still got 2 more days to peak, and they're already looking bad right now in the hospital. So I might say, this virus could get a little bit worse before it gets better, but we have them in the hospital where we have support, and that's what we're doing. We're supporting their symptoms and trying to help them get through it as the virus runs its course. Now we had kids in the PICU 2 weeks with RSV still, and they're still having trouble. So it can last longer. Viruses are all confused now. So we threw COVID in there, and everything's confused. We gave RSV a break for a while. That virus had time to do some different things to itself. So rhinorrhea, don't you love that word? Runny nose, right? Rhino, nose, pharyngitis. What's that? Sore throat, pharynx inflammation, otitis media, ear infection, right? So if you've got all that fluid buildup and your eustachian tubes are swollen, they can't drain well, that could form an infection. That's more long-term. I would say this has initial signs and symptoms, but it could be, their body's still fighting off an infection, which puts their immune system more at risk, and then this virus comes around and bam. So it may start off with that and it makes them more vulnerable. So I would say it would be more like a risk factor. But coughing, sneezing, same, just cold, like upper respiratory symptoms, okay? They can become irritable as it worsens. Why would they have a decrease in appetite? Hard to breathe. Think of the infant who's breastfeeding. So they're nose breathers so that they can breathe while they feed. And then if your nose is all congested, you can't feed. Can't breathe while you eat. Right? So decrease in appetite, although they're still pretty hungry, because they're not eating. It's like they're refusing. Decrease in activity. Some, though, initially look really active. They're just more irritable. It's that irritability. They just can't sit still. I can't get comfortable. So they look like they're active, but they're not active in the sense that they want to play. There's a big difference if you watch how kids acting. Who's the kid that wants to play, and who's the kid who's just agitated and, wiggly that way. Difficulty breathing. This can be pretty obvious, too, sometimes. Retractions, nasal flaring. Apnea, periods of apnea. So we have kind of a time frame for apnea where we're like, when they reach this point, we consider it apnea, but, depending on the situation of the kid, if they've been pretty tachypnic, and then there's this long pause. So that cutoff is 20 seconds. 20 seconds we consider paused breathing is considered apnea. But if I'm watching a kid who's been breathing 76 and they pause for 10 seconds, I count that as apnea too. So it's not like a 19 seconds, nope, we're good. It's not apnea. No, I don't like to play that. But for it, the 20 is there as an estimate. Somebody who's breathing normally with the normal limits that has a pause and nothing else going on with them, 20 seconds would be an apnea. But for a sick kid, it's probably a little shorter than that. And you'll see those pauses. It's like they fatigue after a while, and they just kind of hold their breath for a little bit. Their body's like, wait, give me a second. Okay, and then they start breathing again. And fever is not as common, right? So just because they have a virus and a cold doesn't mean they're going to have a fever. It's actually a little bit more concerning if they do, because what might we think is going on? What's a fever? Tell us.
Infection.
What kind of infection could it be? There you go. Go deeper. Again, this says initial. But the fever in the beginning wouldn't be a very high fever. It's just more of that irritability. Your body's starting that initial response to fight a virus, so your temp's going to go up a little bit. But it's not common. So we're progressively getting worse. So these are the symptoms you're going to see as they get worse. Increased coughing, especially persistent coughing. Wheezing, crackles. These are the kids you don't even need your stethoscope for. You walk in the room, you can hear it in the hallway sometimes as you're walking in. It's like, oh, I hear the bronchi and the wheezing and the stridor. You better get in there, right? Tachypnea, retractions. You guys know what retractions are, right? You watch them in the adults and you chart that too. Copious secretions, not usually on their own. Usually we suction copious secretions, and it's what we find as copious. Pizza cheese. You pull in. Refusal to nurse or feed, so now they don't even want to, they're not even trying. And of course, dehydration, the domino effect, if you're not eating. What else besides dehydration? It's not on here. If they're not eating, what other labs are you going to be worried about? Electrolytes? Blood sugar. Yeah. So they're going to start dropping really dangerously low in their sugars too. They don't have much of a reserve going on. Especially dehydration, that's part of the fluid electrolyte lecture, so we're going to get into that. Getting worse. Severe illness. Respiratory rate over 70 for most infants. Newborn, I mean, it could be over 80. We've had some kids in the PICU breathing in the 90s. Diminished breath sounds. So what's happening when you see diminished breath sounds? What's going on? Say again? Well, part of that, atelectasis, right? Maybe there's so much in there, they're just not even aerating. They're probably not even moving air to those spaces. So the breathing is all happening up here. So what else do you expect to see if you're not expanding your lungs, you're not exchanging air? Hypoxia. How do you know they're hypoxic? Pulse ox, right? So what are their sats going to look like? Really bad, yeah. This kid, right? Definitely below 90. Okay. Tachycardia. Why do you think tachycardia? Compensation. You guys, just be confident. You got it. Compensation. So if you're breathing this fast, right, you're trying to get oxygen to your body. So you're breathing faster because you can't, there's mucus in the way. So for whatever space I've got where I can exchange gas, I gotta breathe faster to get more oxygen to that blood. And so the heart's gotta beat faster to circulate. All right, we got some, I'm gonna send it down here. I'm gonna come back for more, right? So your heart's going faster, your breathing's going faster to try to make up for that. And that's going to make them really tired. So you got listlessness. And of course dehydration is continuing, it's just worsening. So this is not up here for you to memorize. This is just here to show that there is a such thing as a bronchiolitis severity score. This is not from your textbook. I forget where I got that one from. But there's a different score based on where you work. So each facility might have their own type of clinical pathway or protocol. So this is like your Braden score or your Glasgow Coma score. It's just another one of those scales that you can do an assessment on and give them a score. So there's respiratory rate, which is going to vary based on their age. So newborns are going to breathe a lot faster normally. So we have to have a different scale for the younger infants, up to about your toddlers. And then there's a category for accessory muscle use, breath sounds, alertness, dyspnea. Different scales are going to have maybe different things. There might be something specific about activity, some other categories, and they get points. The higher, the worse they are. And then once you get a score for them, then you put it on their protocol. So there's like an algorithm you can follow. So it'll categorize them as either mild, moderate, or severe. And that tells There's a pathway typically for the emergency room and a pathway for the inpatient units. And it's just a tool to let you know how often you need to do your vital signs. If we're gonna do nasal cannula, if we're gonna move to more advanced care, high flow nasal cannula and other support. Or if they're PICU category, for example. So it's nice. It was a way to kind of keep us consistent with our treatment and go with what's evidence-based and what we're doing. So this is just one piece of it. You get that number and then you plug it into the pathway to determine what's next. So this is when the physician provider is gonna create some orders for you for what you need to do for your interventions. But it's good for us to know at what level should we, and what should we expect from our provider. So I have a scale, we're gonna work on this later, but I have a scale to pass around to you with that clinical pathway, and we'll work through a case study with that, just to get you used to it. But I wish I had saved one from Baptist. So it's like we had, I think on a badge buddy, it was just a modification of an asthma protocol. So there is an asthma clinical pathway. It's really nice to have these. It kind of tells you, and it might be a way to get some standing orders too. But you can work through a case with it. So we'll try it out with a case study. We're gonna start off with of retractions. Little toddler here. We're looking at retractions. Some noisy breathing. Pause it really fast here. Back it up. I want you to watch his abdomen. So we're looking at abdominal retractions here. And if you didn't have that shirt in the way, you probably would see some suprasternal retractions. And look how tired he is. I mean, we could probably put him in that little bronchiolitis severity score and get maybe a moderate on this kid. But yeah, watch, these goes a little bit quickly. So, I mean, you can see the retractions through his shirt. This one's a little more active, a little more mild. But you can see the subcostal retractions underneath that belly breathing. Now we're going to work, right? Different kids. Okay, on this one, we've got some subcostal retractions. We've got some intercostal, and if their neck wasn't so chubby, you'd probably see some suprasternal or supraclavicular. So when you're watching retractions, the higher up you go, the worse it is. We start down here, we start to get into the ribs, intercostal, subcostal, intercostal, and then suprasternal, the sucking in right here. Some tugging, we call that too. Or the supraclavicular. Higher up, the worse they're struggling to breathe. I don't think we have head bobbing in here, but there's some head bobbing with it too. It looks really cute. If you play some good hip hop, it looks like they're dancing to it. But if they're breathing, they're bobbing their head with their breath, they need the emergency room or a PICU. Because we're moving up higher, right? That's like a head retraction, right? Look at the eyes on this kid. Not quite bright-eyed baby. It's not quite nap time. This kid's been fighting, working hard, losing energy, right? Maybe a little bit pale on their skin. So nasal flaring is going on. So it doesn't have to like flare with every breath. Sometimes they just keep them wide open. That's their body trying to get as much oxygen through as it can. Keep going. Too tired to cry. You good at breathing? Oh, okay, so let me just go quick. Just trying to find some really good videos for you all, but I didn't show. Okay, I got another video after that one. I just want to pause here for a moment. Talk about diagnosis, right? So, most of the time, and anytime, like during COVID, we got really reliant on a test, on a swab, a PCR test. There's a PCR type test for RSV as well. But everything in the past has always been based on symptoms. History and physical exam, number one, okay? Clinical symptoms. The tests, the swabs are nice to confirm the type of virus, but tests can fail, right? So they're not always reliable, but if you take that test along with a set of clinical signs and symptoms, then you get a diagnosis. Again, that's a provider's job to do is to diagnose the disease process. Important for you to know, have you heard of the BioFire? Okay, BioFire is kind of what we're using now. It tests, oh gosh, I can't remember how many, a whole bunch, like 20-something viruses. It's really expensive, but we'll use it in the hospital. I don't know about the primary care setting, but they can do a rapid BioFire. They can do a rapid RSV swab too. You can get the results in an hour, or they can find out any other panels. So this is how we were finding out that they had rhinoentero, parainfluenza, I can't think of all the other ones, all the other respiratory viruses. So, yes, so the BioFire and the enzyme-linked immunosuppressant assay, they're ELISA, or the common ones. But we usually default to that BioFire, a PCR, or a rapid single-only RSV swab. If the child's been exposed or somebody in the family has had RSV, we don't always do this. The symptoms, the color of their snot, pizza cheese, it's RSV. It's usually RSV. So they don't have to put the kid through another swab and put them through that kind of stress of a nasopharyngeal swab to find something out there we already suspect. There's nothing we can really treat it with medication-wise. We're going to be treating their symptoms anyway, so it doesn't change the care that we're providing just by knowing what the test says. Okay. So, hope we won't play. Okay. So this is 2 cases. These actually are old videos. They're probably, I think they're from 2010. It's an ER doctor who got permission to put all these kids on YouTube by the parents, but he's a doctor in Georgia. He got his training through the Army, so he was an Army doctor for a long time. Many of you wouldn't think that we would learn pediatrics so much in the military, but so he's an ER doctor and does a lot of these training videos, but I like them because it shows you kind of the process of what's going on in an emergency room as they're working up this kid. But look at the color on this poor baby. Okay. His palms are super blue, and that might be just a melanin on his face, like a lack of melanin, but he's got the blue color, I mean, just his mouth. It's a little bit, I mean, that angle, wait till the video shows, but you'll see kind of grayish palms. The next child, their color is even worse, but you can watch the retractions. They're gonna show you a little bit about their labs. It kind of goes a little quick. You don't have to be like, you don't have to take notes or anything, just kind of listen to what they're doing and how they're working through this.
And summer on a high note at the Living Spaces Labor Day event, where you'll discover the best deals for your home.
This glucose was on coming in at about 20, and is that very, what last?
I'll pause real quick so you can see that. What stands out to you? Obviously they highlighted some, but within the highlighting, what do you see? Well, all of it's yikes. What's the glucose? Yeah. Less than 20. Where's the potassium? 7.7. Is that high? Yes. So do you guys remember your acid-base balance a little bit? What do you think this kid is? So what's the pH? 7.2. What does that mean? Acidotic. Okay. Where's the CO2? Is it on here? CO2. Oh yeah, there it is. CO2 is what? So when your pH is low and your CO2 is high or reversed, what does that tell you? Respiratory acidosis. Right? Which is what we suspect. It's not a big surprise, but it's pretty scary. Pretty scary labs. All right, let's keep going.
60. And this false ox, yeah, very weak effort, the false ox is like 60%. And you've got a jet med, you've got some IV glucose, got some IV fluids. And been sick for about 3 weeks. Very long. 76 times a minute. been doing his belly breathing. See what his chest X-ray looks like. So this will be a second tip, and then we'll do a second IV on him. And
sorry, let me keep pausing it. Something I have a habit of doing is looking at the diaper. Can you tell by looking at it? It's dry. How do you know? It's missing the blue line. So diapers, if you didn't know, usually will have a color changing line down the middle if they're wet. So I'm already thinking this kid looks dehydrated, probably is dehydrated, but they haven't peed yet too. He's probably been in the ER a little bit and diaper still looks dry. They could have just changed it, but this is a habit to go towards that. So these are you're thinking of hydration status, all that blowing off too, that insensible fluid losses. I'm just giving you guys preview for a little bit later.
his temperature was, what was his temperature, guys? 38.1. And his PCO2 was 75, around 75, pH 7.2 something.
We'd like to hear that. That means we're feeling better. Yeah. I thought you wanted to cry, but we'd like to hear that. I'd like to hear that cry. Are you getting better?
He escaped it, I think.
Oh, you look at that. Going straight up. See it? Straight up. That might be where that one goes. It might take the curve.
This guy has some weird trumpet music in his videos. So patient number 1 looks pretty sick, right? Now when they were showing the strips from the iStat a little bit later, you could kind of hear him in the background. I think he started to perk up after some treatment, and the video's just kind of edited a little bit. But yeah, it looks pretty sick. I mean, these are the kids that when you look at them, you know, oh, that's not right? But you can see all the things we were talking about, right? What kind of retractions did you note? How would you document some of those? What did you see? You can describe it, like if you don't know what they're called. Under the ribs, on the bottom. Yep. So subcostal, right? Costal is your ribs. Sub underneath. What else? He had more. Just point to where. Stomach. So that's the subcostal. So there's some belly breathing. Yeah, that's fine. Yeah, it just tugs on it. So yeah, you're fine. You got it. So what are the accessory muscles? Yeah, the neck muscles. I didn't see so much head bobbing, but of course he's laying in the bed a little bit too. Yeah, and you could say some of the abdominal muscles are accessory muscles in a sense too. So, did we have intercostal? I think so. It's harder to see sometimes on some of the babies with the big belly protruding. What about, did he have any supraclavicular or suprasternal? Hard to see. But yeah, looking at his condition, he had full chest retractions, everything was going on. If we sat him up, he'd probably have the head bobbing too. Okay. Second baby.
Something like this for how long?
She just started a little bit last night, it stopped. And then she woke up this morning and was just crying.
Constant cough. All right. She running a fever at home? All right. No fever at home. She eating all right? Okay. She ever turn blue or have any episodes of stopping breathing?
No.
No? Anybody else in the family sick?
My sister got a cold, I think that's where she got it from.
Okay. And is she in daycare at all?
The regular pertussis test, that's been all it is.
So now we're, this is nebulized epinephrine. We're doing, how much we giving her?
2.5 in the.
Of the 1 to 1,000? All right.
Yeah, almost, yeah.
All right, so her coughing slowed down, and her, she seems to be breathing a little bit easier, still breathing very fast. The abdominal breathing, but I don't see as much intercostal or subcostal retraction going on.
We'll stop right there. But I wanted to show you that cough, persistent, which is, you heard him talk about pertussis too, because that's a persistent cough as well. So I double check that and make sure. But, yeah, here's her gas. So, respiratory acidosis again. No big surprise. But the racemic epinephrine neb that they gave her helped her. I think at this point, this was 10 years ago when we had that as part of our protocol. So that helped her, but she finally was getting a little bit of rest. Even though she has a hypopigmentation in her face, you could see how gray and pale she was in the undertones. So, and her thumb was a little bit more pink in the end there. I don't know if you caught that. But I bet if we'd have a little bit of refill normalized to her fingers at that point. But yeah, exhausting, right? I'm sorry, that's so depressing. But that's what it looks like. So, on to the supportive care, which is what we're doing. We're not treating the actual virus, we're supporting them. So, suctioning and maintaining the airway. Think of your priorities, airway, breathing, circulation, right? That is gonna be our priority here. Getting that stuff out of the way, because what does that help them do? Helps you breathe, gets that oxygen in, right? So we need an airway before we can get that oxygenation going. So we can do that by the bulb suction, which is preferred, because if that's working to help the kid perk up and get them oxygenating again, we can send them home with it, right? But if that's not enough and we need wall suction, we probably need to admit that kid and do some more plumbing and getting some of that stuff out. Supplemental oxygen. And so we're doing that a little bit less. We actually lowered our threshold with that. We're not immediately going right to oxygen. So it used to be like if their sats were less than 92%, we would go ahead and put the oxygen on, but now we've kind of lowered it. If they're below 90, then we might put the oxygen on. And the rationale behind that has to do with this obstructive piece. So what do you think that means then? Why would we not want to give oxygen to somebody with a respiratory problem? Or not want to push it right away until they really need it? Say it? Not necessarily. Think of like your adults and COPD. Everybody's like, oh, I didn't know that. What? CO2 levels, yeah, air trapping too. And that barrel chest. So what they're doing is they're getting that oxygen in and they're not able to get that CO2 out. So it gets trapped in there. So we can actually hyperoxygenate them too much. So that's the reason why I said, let's wait a little bit, let's get this out of the way so then they can properly oxygenate, but because if we throw oxygen in there with all that obstructive type mucus in there, we can have some air trapping going on. They can get that barrel chest too. You can see that overinflation too on their x-rays. So, yeah. So adequate fluid intake, right? Think of the insensible losses. You see how fast she's breathing, right? So we're losing hydration that way. Plus, they're not drinking, so we know they're dehydrated because they just aren't eating either. So there's another priority. Antipyretics. What are those? Acetaminophen, I hear? You guys are very quiet. Tylenol. Are we giving that for a fever? Yeah. Maybe. We can give it for comfort too. Think of how you'd feel if you were coughing for 3 minutes straight. I'd have a headache, right? Maybe a little sore throat too, so if it's pain relief. Antibiotics only when you suspect a bacterial co-infection. And so this hypertonic saline nebulizer is something that they'll do. It's not recommended anymore. It's one of those that we used to do that they say the evidence really doesn't support it as helping. But it's okay to try it, and if the kid perks up, we'll do it. We just might do a one-time trial. If if it doesn't show anything, we won't keep doing it. But, can you think of why that might work? So if we're doing nebulized hypertonic saline, what is hypertonic saline?
Isn't it because like on hypertonic fluids, you have to watch their lung sounds because it could cause whatever it's called, like fluid getting in their lungs?
We're putting it in their lungs. It's nebulized, so it's not an IV, is that what you're thinking, like IV fluids?
So, and then it coughs it out easier.
Well, what is hypertonic saline? Higher sodium. What does sodium in water like to do?
It pulls the water.
Yeah, it's pulling that water in to help thin those secretions that are in there. So we definitely need to be hydrated to do this too, which is another reason why they're like, let's not do this, because they're pretty dehydrated too. So it might be pulling their own fluid reserves, but it's to help loosen up those secretions and help that sodium bind with their secretions, the water that's in their secretions, but again, they're thick secretions. Hence we don't really recommend it, but hey, it might work, so let's try it. So some ongoing assessment, this is a little bit of a change too. Vital sign monitoring per protocol or per whatever bronchiolitis clinical pathway they may have. So you might be doing more frequent vital signs if they're higher up on that score. If severe, we might do continuous respiratory monitoring or continuous pulse oxygen. So that was routine for like 20 years of my pediatric career. Slap a pulse ox and slap a CRM on them. I had monitors on all the kids. Anybody work peds? You have it, kid. Anybody? No? Peds? Oh, wow. Inpatient? Do they have monitors? What do they do with the cords and everything that attached to them?
Some people have like little tape things to tape them together so they don't like get under them and stuff.
So she's talking about taping them on. Well, you said so they don't get,
Yeah.
because they move around a lot, right? So they've got all these leads and they get a pulse ox. Easy way to
they put them in the
piss off a
diaper.
baby is put a pulse ox on their toe and they go whoop, right to it and pull it off. And then you got the dinging and the alarming and all the annoying stuff going on. Or they're alligator rolling in the bed and they're getting all twisted up in it. And you're constantly detangling all the, how many times you have to undo these cords. And how are these kids not strangled with these things around their neck and the cribs? The cords are a nuisance. But it's annoying to them too. They're irritated by it. The alarms go off. They can't get any sleep. They're exhausted. So we're doing a little bit more spot checking to give rest to the parents and rest to the kid and give us a minute to take care of the kid and not worry about the cords. Right, so we're doing a little bit less of that. Care and management, on the nursing side, RSV, assignment clustering. Again, these are exhausted kids, so we're gonna cluster our care. We're not gonna be barging in, oh, forgot a 10, let me go back in. Right, we'll try to think of everything, get it all done at one time, give them periods of rest in between. Obviously, because of the contact and droplet precautions, I don't know of any hospitals, at least around here, that aren't private rooms for pediatric kids anyways. But we would reduce visitors, so they're usually gonna have a sign in the door, because we don't want them taking RSV to the nutrition room, get a drink, or down the cafeteria, now we're spread RSV all throughout the hospital. So, kind of talked about this already. We probably could put ineffective airway clearance in there too. Oh, it is there, it's just not up at the top. I might have forgot, I did that on purpose to ask you guys, is it in priority order? So what's your priority diagnosis out of this? Priority nursing diagnosis. What would you pick as number one on your Centaur care plan? Say it loud.
Ineffective airway clearance.
There it is. Gotta clear that air before you can get oxygen in there. And then what's next?
Impaired gas exchange.
Yeah, you could go both with gas exchange and what else?
Ineffective breathing pattern.
Breathing pattern and gas exchange. So if we clear the airway, we get the oxygen, we might actually fix that breathing pattern issue with the oxygen, right? Then they don't have to breathe as fast. But there's a lot of other reasons why they have an ineffective breathing pattern. It's the mucus you're hearing in their lungs, So a lot of this is where that concept mapping comes in, where you have all these problems you're addressing, and certain interventions can kind of help fix more than one problem, right? So that suctioning helps clearing the airway, helps with their breathing pattern, because now they can breathe clearer, and helps with that gas exchange, right? That's cluster care too, when some of your interventions are helping more than one problem. So fluid volume deficit is, yes, it's, all of these are super, super important, of course. But we gotta clear their airway so that they can drink, right? Get them breathing so that they can drink, because we are gonna try to, we're gonna prioritize the PO fluids first, always. You don't wanna put an IV in a kid, you don't have to, okay? If they can tolerate the PO, then let's keep going with it. But if they can't, then we have to go to the IV. Okay, so this is just more of the interventions we were talking about: bulb suctioning, if ineffective, use the wall, PO fluids when possible, NG tube. So some of these severe kids, we will drop that NG tube and we will hydrate them and feed them that way. And it depends on where you are, but some places we will actually make them NPO if their respiratory rate's above 60. So if they're breathing too fast and you try to slap a bottle in their mouth, they're gonna choke on it, right? They're gonna breathe it in. So it's an aspiration risk for aspiration. So we'll put an NG tube and we'll feed them that way. That'll help perk them up. Once we get them hydrated, it's a different kid in there. All right, and that's how we treat viral infections. We treat them with fluids, right, and rest. That helps your body to fight them off better. Okay, and monitoring respiratory status, however your clinical pathway recommends. And then obviously open communication, there's all kinds of interventions in there. Hand washing, number 1, don't kiss the baby. We all do. But we meant it when we were talking about it in 2020. All right. So we can't leave this part of the lecture without talking about immunizations. So it's not really even an immunization, it's more of a medication, monoclonal antibody that we can give to help prevent, not treat, but prevent RSV. And so in particular, we're talking about palivizumab and nirsevimab, which is a new one. My next slide, yeah, this is the slide I want. So we've got palivizumab, which has been around for a long time. This is, it still is prioritized for our premature or our higher at risk, already chronically ill, chronic lung disease, especially prematurity, or infants born during, with a high risk infant born during RSV season especially, they're gonna get one before they leave the hospital, or at their first checkup. So there's a lot that's in there, but that's big, and that's still around. But the palivizumab is a monthly injection. So it's not fun, but they can still get RSV again. So that's just about how long that's gonna last for, that immunity. It's basically binding to that virus so that it doesn't then replicate. And then nirsevimab is more long acting, so this is a one-time injection for the season. Right, so it lasts a little bit longer. It can be, you don't have to be high risk, just an infant less than 8 months born during RSV season. Or if they are higher risk, they can get it for the second RSV season. So that's nice, right? You don't have to be premature or high risk, because our healthy babies get it too and still end up in the hospital. Healthy in the sense that they don't have these chronic complications of other diseases, or they're not premature. Just full-term babies can get sick with RSV also. So it's nice to have that, but last year, they ran out of it. So then they had to go to be specific about who could get it. So hopefully that doesn't happen this year, that'll be available, but that does happen. I mean, we ran out of that for COVID too, right? We had monoclonal antibodies and we had to be real specific of who could get it. Nice thing is it's a one-time dose, so now, probably for this season, if they qualify for palivizumab, they're probably gonna get that, because they're gonna reserve this for those who don't qualify. So if they're premature, they're probably gonna go ahead and get the Synagis is the brand name. I don't know if you've heard of that one. They'll get their monthly injection during their RSV season. They don't need it all year, it's just during the season. So that they can reserve these for the others who qualify. Okay. I just like these staring face. So that's the RSV. We can take a break and come back. We can talk a little bit about, maybe real quick on that case study, we'll get into cystic fibrosis. So 10-minute break. Come back at 2. Ooh, perfect timing there. 2 o'clock exactly. We'll do 2:10 to get back to it. He's from the one of the vaccine or the injection commercials, like their website. I thought he was like, huh?